Hi everyone, I'm Dr. Faisel Sayed.
And I'm Dr. Dan McCarter.
And you're listening to Faisel and Friends, where we believe access to primary care is a right, not a privilege.
Faisel and Friends is brought to you by Primary Care for America, a diverse collaboration of innovators leading the way towards comprehensive, continuous, and coordinated primary care. Today, we're talking to Dr. Jeffrey Davenport from the Direct Primary Care Alliance about direct primary care, a rising tide for American healthcare. Let's get started.
Well, we're over here at the 2025 National Conference at Futures, and we've got over here with us Jeff Davenport. Good to see you, sir.
Nice to see you guys. Thanks for having me on.
We met Jeff at the Primary Care for America meeting at the National Press Club, and he really, he put a fire under my butt with direct primary care.
Yeah. So tell us which group you're here with, Jeff.
So I actually represent the Direct Primary Care Alliance, which is a physician organization with the mandate to educate people about direct primary care, and especially try to help medical students, residents, and physicians learn about the model and potentially go into the model if that's what works best for them and their patients.
What led you to make this mindset shift? I mean, it's a big shift with being a family doctor and then saying, hey, I'm going to become a business person.
Yes, this was years ago for me. I've been in DPC now for 11 years, but back in those days in the fee-for-service world, I was already getting pretty burned out, and I was thinking, dadgum, I'm not even 40 yet, and I already don't like my job. And that's a rough place to be in when you spend so much time and energy and money and effort becoming a family physician and finishing residency and going into the debt that we go into to be in the middle of a job, and you love seeing patients, but you don't like all the stuff that comes with it, and it's affecting your family life. It affects your ability to parent your children. It affects your ability to be a spouse. And we all talk about burnout all the time. And so I was there, and I was already trying to figure out there's got to be some other way to do this. And I had some ideas roaming around in my brain, and then I met Dr. Josh Umber. He's out of Wichita, Kansas at Atlas MD, and he described direct primary care, and he was just describing his own practice at that point. But I was like, that's it. And I literally, a switch flipped. I said, that's it. That's what we're doing.
So how many patients do you typically have in a panel? We hear the number for the fee-for-service primary care docs of 2,000, 2,500 patients in a panel. What does the average DPC doc?
I typically quote the number 2,500 to 3,500 for fee-for-service. In direct primary care around the country, we're probably in the 400 to 600 range on average. Pediatricians, DPC pediatricians tend to be a little bit lower than that. There are certainly some DPC doctors who feel comfortable getting up in closer to the 1,000 range, but those are unusual.
Yeah.
But 400 to 600. So I personally have 600. I used to have 3,000. It's 80% fewer patients to take care of. And so it just allows me to take care of those 600 much better than I could.
Well, but we hear about this shortage of primary care doctors, and how does cutting the size of the panels work if you're doing that? If you're going to take care of 600 rather than 3,000, how does that work?
So I have so many answers to this. I talk about the urgent care clinics. Why do we even have urgent care clinics? It's because we cannot get into our family doctor. They're seeing 30 people today. They can see you on Tuesday. Well, that's very helpful if I need to be seen today. So imagine every urgent care provider doing an actual primary care practice rather than urgent care. How many ER visits are really primary care visits? It's nearly 50% if you talk to the ER people in the ER literature. Earaches and rashes and even minor fractures, things like this that they're not emergent, they can be handled in a family doctor or a primary care practice, and they aren't. And then I talk about all the other specialties. We just finished with the DPC Summit last week, and I asked everyone to raise their hand depending on specialty. We had ER physicians in the room, we had internal medicine, we had pediatrics, we had hematology. You gentlemen just met one of our board members, Dr. Laura Kinney out of Missouri. She's a hematologist, but she has a panel of 200 primary care patients. Well, Imagine if all the specialists, if they wanted to, we're not forcing anybody, but imagine they're already seeing, the endocrinologist is already seeing the diabetic repetitively. Imagine if they just ordered their colonoscopy along with it and took care of some of the other chronic stuff, which the endocrinologist is innately qualified to do. And then on top of it, it's very emotional. I'm not trying to be flippant about it, but, physicians' suicide is significantly higher than the average suicide rate of the American people as a whole. And then also physicians get burnt out and they retire early. So imagine all those, late 50s and 60s and even 70-year-old physicians who are just like, I can't tolerate this stuff anymore. I like seeing patients. I like being a doctor, but I just can't take all the stuff that comes with it. Imagine if they continued practicing. And then, one of the phrases I've uttered more than once is, unfortunately, if a physician commits suicide, how many patients can that physician see? And so if we help physicians function better and live a happier, healthier life themselves, and we try to prevent those types of horrible outcomes, then they're productive and they continue seeing patients. And then we incentivize the young people, the students and residents, to go into primary care because they don't want to go into primary care in the system the way it is now. So we introduce them to this model. And of course, that's a movement that will take 5, 10, 15, 20 years. But once they see how we can do it rather than how it has been done, I think there's going to be more primary care opportunities for students and residents.
Yeah, this is a way of finding joy again. So many of the doctors have lost the joy. That's exactly what you described. So many get like, oh my God, I got to click on this. I got to do this. I got to do that. And it's just like, you've got the person in front of you. I mean, and when I was in residency, we were in residency when we made the transition from the paper chart to the EMR.
EMR, yeah.
And I remember all the promises that were being made in those days. Do you remember, like,
it's going to be so much better. You'll be so much more efficient.
And then now you got to look in the computer. Before we'd make rounds in the hospital, and you get all the information in rounds. Like everybody knew. The doctors would be making rounds at some time in the morning. We get all the a tech would come and say, "Oh, so and so's family member came in and said that, or so and so said this," and we didn't have to look anywhere. It was all right there. And but now I feel that with the AI, I feel that we're at a point where the promises that were made 20 some years ago, we're starting to see that. And I'd love to hear how you're using this technology in your regular day-to-day practice. Let
me put it this way: I think it's very important to recognize AI as a tool.
Yep.
I have a stethoscope. That's a tool. The stethoscope is not the doctor.
Yep.
There are some people who believe that AI may replace doctors. Until AI can touch another human being with a human hand, they're not going to replace us. I'm a sci-fi nerd, so you still see Dr. Bones McCoy on Star Trek, and he's the old country doctor. He just has that fancy thing in his hand that he waves over. It's a tool. So AI is fantastic because it will help us make fewer mistakes, I believe. We are human. We make mistakes. It will expand the opportunity for us to collect information faster. My dad used to my stepdad's a doc. If he had to look something up, he'd go get a book. Now I do a Google search. Pretty soon you'll just say, hey, AI, tell me about XYZ. And so but it is still just a tool. So me personally, I am using AI to help. So I verbally, I just turned on an audio recording in the room with the patient, and then it gets transcribed, and then I do an AI interpretation of a note. And it's a pretty good system. There's still a few mistakes here and there. Sometimes I did not hear any crepitus, and it will say patient had crepitus. I have to correct little things like that, but it just allows me to do the note faster and better. And then it's a little bit more expansive than my notes. It remembers a few more details than I would have just off the top of my head, 20 minutes after by doing the note. And so I think it's going to be a fantastic tool. It'll be really, really incredible when a doctor who has been well-trained sees a patient and they're puzzled. And they're like, let me do some research. Let me think about this. Let me, get on the computer and see what I can come up with. And even with just a regular old search right now, what I always tell my patients, they go to look something up, but they don't know the fancy doctor terms.
Yep.
They'll just be like red dot on leg. and I will say erythematous nodule on pretibial area. And my search works better because I'm a physician. And so that, I think, is where AI and the computers come in, is we do the learning, we get the expertise, and then we use AI as a tool. But AI still cannot touch that person. And AI still does not feel what that person feels, and I do. And so I think it'll be a great tool, but anyone who thinks it's going to replace doctors is a fool.
Yeah, it sort of reminds me, I think it was in one of Stephen Covey's books. He said everybody needs a watch and a compass because you need the compass to tell you what direction to go and the watch to keep time, but no watch tells you what it's time for. And so AI probably doesn't tell you, it expands the range of possibilities, but it doesn't necessarily give you the one right answer in that situation when you're sitting in the room with the patient, which I think it can help us be stronger and do more and expand our capabilities if we work with it, but shame on us if we ever let it take our place.
Amen to that.
Yeah. At the end of the day, I feel like even with us as doctors, the shift has happened. We've gone to the extreme with all the checking of the boxes. And now it's like, we don't like checking boxes. We like being nudgers and influencers. We like to influence people, and now these tools we're making that move back because none of us got into this to be billers or clickers or any of that stuff. So I feel like this is just a great way to find joy again in medicine. I'd love to get your thoughts with the changes that have happened with the way that now we can use health savings accounts to pay for the monthly memberships. I mean, what does that mean to you finally after so long? I mean, it's one of those crazy things. If you don't know why don't you go ahead and explain the situation to like a resident or a student who may not understand?
For years now, direct primary care, all of us normal people recognize that it's actual medical care. But at the governmental level, at the level of the IRS, it has continually been identified as, and I won't get all the terminology correct, I'm not that much of an expert on it, but it basically identified us as some version of a health plan. And we're not insurance in almost 40 states now. There's a state law that identifies direct primary care as not insurance. And so even at the state level, almost every state recognizes that we're not insurance, but at the federal level, we were considered a plan. And so people, not only could they not use an HSA, which is a health savings account, for those of you who don't know, you fund a HSA tied with a high deductible health plan, and you can use the HSA to pay for medical care. And there's all kinds of things you could pay for medicines, you could pay for labs, you could pay for doctor visits, you could pay for cosmetic surgery, you could pay, in certain circumstances, you could pay for a gym. And yet you could not pay for direct primary care because we were identified as a plan, and you couldn't have a second plan along with the first plan with the HSA. This is way too ridiculous. If you just got lost there, it's okay. I've been lost for 10 years. I don't know why this was so hard. However, here we are now, finally, and at the federal level, the IRS has finally agreed that direct primary care services, which is patient care, is not identified as a health plan. So now it's a service, if you want to use that term, and you can use HSA dollars to pay for that service, which is good because HSA dollars are triple tax protected. They're like tax deferred and tax forgiven, and I don't remember all the tax stuff. So when you're paying for when you're paying for a DPC, you can use these HSA dollars, and so it's less money out of your pocket, if you want to look at it that way. One of our colleagues, the vice president at the DPCA, did some math. If you're paying $100 a month for a person and you're in the 22% tax bracket, it saves $284 over the course of the year. So multiply that times a family of 4, for example, or at least multiply it times 2, because I think $300 per month is the family max. But still, it's legit money, savings out of people's pockets. And so now you can pay for DPC services with an HSA. And I think I was actually in Washington, D.C. at the press club again, and we were talking about this. And one of the gentlemen in the room, I think he was a banker representing the HSA accounts. I called him the HSA guy. I apologize. I don't remember his name. But he gave me a statistic. 61% of HSA accounts are identified out of zip codes that are lower socioeconomic zip codes. That was fascinating to me. I would have thought HSAs were mostly people with like more money than average, but that's not true. 61%. And so the other statistic that they're giving us is now 61 million people who have HSAs can now pay for a DPC practice. And that's a lot of people who maybe wanted to do DPC, but were afraid that they would get in trouble. I will tell you, there's been people using their HSA for years already in almost all of our practices. But now we know it's okay, starting January 1 of 2026.
So let's say if you're like your typical primary care doctor, you've been wanting to do direct primary care, but there's a lot of concerns of, oh no, I'm going to have to opt out of Medicare, or I can't do this, or I can't have a mixed practice. What does this mean for a doctor who's like, and think about your typical primary care doctor with margins of like 2 to 3%. I mean, nobody's living like in the like. What does this mean for them?
Well, this specifically just creates more demand. If you're looking at the supply and demand, right? Now that this law is passed in January 1, there's going to be companies that can now do this. Even my own practice, I have myself, my wife, and a daughter who work for me. We cannot pay for our direct primary care doctors out of the company. But guess what? January 1, that changes. Yeah. So that saves me personally money, you know. And so I think there's going to be companies, there's going to be people who have HSAs. We just said 61 million people. It's a lot of people. So the demand is going to be higher. And change is hard, so I think the main impetus for not switching to DPC or the main obstacle is change. But if you can, as a physician or as a medical student or resident, if you can think outside the box and do something different, the supply or the demand for direct primary care is going to go up drastically over the next several years as more and more entities recognize these types of tax benefits and just the benefit of being an employee or a patient inside of a direct primary care practice. So if you're a doc, there's no time like the present. Make the switch.
So it's sort of like when you're talking about changing the system, it reminds me of hearing about in some of the third world countries in Africa when they went in to put phone systems in after we started developing cell phone towers. They didn't go drag wires for hardwired phones. They went in and put up cell towers. It was cheaper, it was easier. I'm wondering if that's the kind of transition you're talking about happening here. For people who have never done fee-for-service, which is pretty complex, honestly, then you get to do a simpler way of doing this. You just pull your iPhone out of your pocket and it works. You're not worried about, have you got it plugged into the right place in the right room and that kind of stuff. So it could be very interesting. Now, one thing about it is employers can actually now offer DPC as part of their high deductible health plans as well, which is at least the studies I've seen show that good primary care saves 20 to 30% in healthcare spend. I also heard on this week, I don't know if it was Milliman, somebody quoted that the average cost for employer-sponsored healthcare per individual in the United States is now $16,000 a year. So you're talking about being able to save $5,000 or more a year. Now, tell me again how much per person, and how much of that would have to go to the DPC to pay for that care to save that money?
Well, every DPC is different. There's a range of expenditures across the board. I will say the federal law that just passed, it does put a cap on that. And some of the physicians are not happy about this. However, it is tax revenue that's not going to be collected. And so they wanted to protect that. Some of the estimates were a $16 billion tax hit if there was no cap on it. So they put a cap of $150 per individual and $300 per family. And so now the impact is about $2.8 billion. So that's what the IRS was willing to agree to. But that is actually $150 per person per month is actually higher than the average. Across the country, the average for direct primary care tends to be in the 60 to 90 range.
But even if you were spending the maximum,
Yeah.
so you're spending $1,800 a year.
$1,800 a year
to save
$5,000.
Yeah, I mean, I don't know about you. I would do that all day long.
Yeah.
If I could stick my retirement account into a return like that, that's where it would be.
Exactly right. Well, so, I mean, you said it. We've had study after study after study because for 15 years we've tried to look at the economics of direct primary care. And it is somewhat of a challenge because, we're doctors. We don't play in the economic realm. And so tracking these things has pretty much always been a secondary target. But repetitively, anytime someone has looked at these things, you're throwing some numbers out there, which are fantastic numbers, but it's easy to explain. If you have good primary care, even great primary care, we can take care of and this is a guesstimate, it's just a number that people throw on, 70% of the problems for 70% of the people, 70% of the years of a person's life. If you're in a car wreck, I can't solve that problem. But if you fall on an outstretched hand and you're like, oh, my wrist, I think it's injured. I think it might be broken. Should I go to the ER? Well, that's a family doctor problem. If the bone's poking out, yes, go to the ER, don't call me. But if you think it's broken, I can order an x-ray, we can do a splint, save you an ER visit. So when you do direct primary care, you have decreased ER visits, decreased surgeries, decreased hospital days, decreased advanced imaging studies, decreased referrals to specialists. And so even just those 5 things, think about how expensive those things are. Surgery, hospital, ER, advanced imaging studies. If you decrease all of that, well, you save a lot of money. Now you spend a little bit more incrementally on the primary care, but primary care is not expensive. Even $1,800 a year. That's not a huge expense for a company health plan. But saving multiple thousands of dollars on the downstream because you avoided a surgery because you got in to be seen on time, or because you avoided an ER visit because it's really not an ER visit. That's pretty easy to see. It's not complex.
But even on the opposite end of things with prevention, like when in the fee-for-service model, we're in this situation. Oftentimes we're in front of somebody when you got thousands of people. You know them and they may know you, but are you chummy enough to have a conversation about prevention with somebody who's prevention hesitant?
Prevention and chronic disease management, these types of things. In a fee-for-service world, you really get about 8 minutes with the patient. It is hard to develop a relationship. And we all know that trust in medicine is hit or miss depending on the person. And so developing a rapport is the only chance you have at affecting outcomes. I always use the example of one of my patients. She was literally a bilateral amputee when I met her because she had terrible diabetes. And it took me 5 years to get her to quit drinking 7 liters of Sprite a day. 5 years. This is also why I tell people you cannot collect data to determine how well primary care is doing. Because for those of you who are not doctors, these numbers don't mean anything, but her hemoglobin A1C was bad. It was 13, 14, 12. I never saw it below 10. If you don't know what that is, it's supposed to be around 7. And it took me 5 years to break that habit on her. And just me continually pounding her, not in a mean way, but just in I'm not giving up on you. I'm not giving up on you. And, she trusted me, but still over time, we finally succeeded. And for the first time in history, her A1C was below 10. So there was still a lot of work to do. It was still 9, but still I had a lot of work to do. But that is the type of thing that you cannot quantify with data. And so when you're talking about chronic disease management or prevention, I mean, vaccine hesitancy or cancer screening hesitancy. Well, every single time I see them, I know them well enough to be, I kind of make a joke out of it. I was like, when are you going to do this colon cancer screening? I'm going to keep pestering you about this. They understand that they can tell me no, and I'm not going to be offended. But they also know that it's my job to educate them on these things, and I'm not going to quit doing it. And so we joke and play around, but we have a relationship. And I can do that. In 8 minutes, I'd be like, are you going to do colon cancer screening? And they'd say no. And I'd be like, all right, your choice, whatever. Doesn't hurt me. I wouldn't say that out loud, but, I don't have time to really think about it or care about it. I just have to take their answer and move on versus in this model, I get to actually talk to them about it.
And one of the, when we ask doctors about a patient going to the emergency room in a fee-for-service world, it's like they kind of raise, okay, well, what could I have? But when one of your patients, if you found out, let's say it's Monday morning and you found out one of your patients went to the emergency room the night before without telling you, how would you feel?
Well, this happens fairly frequently. Some doctors, you were talking about some of the doctors switching, some doctors are worried about being on call all the time because most DPC is available after hours and on weekends. I actually have more often where a patient will go to urgent care or the ER rather than bother me on the weekend because they know me personally. But then I have to chew them out. I'm like, what are you doing? They're like, well, I didn't want to bother you on Saturday. I'm like, that's what you pay me for. Don't go to the ER unless you call me first, And that doesn't happen that often. But there are times where someone will be sick. I don't want to be graphic, but it's like, well, I've been pooping like crazy since Saturday. Well, why didn't you call me? Yeah. Like, text me. That's what I'm for. Well, I didn't want to bother you on the weekend. I'm like, dude, you're pooping 6 times a day. Call me. And so these types of things are exactly what we're here for, is to try to minimize that out-of-office care. And honestly, there's a lot of those visits that don't need to go to the ER. So it's expensive and misallocation of resources. And so,
What's going to happen to the poor hospitals who lose their fast-track option in the emergency room?
Well, they'll have to become more efficient, I suppose.
Well, thank you so much for coming out. I wanted to, before you leave, and officially on the record, this is just a quick 3-4 minute conversation. But you're here at the conference, you're meeting students, you're meeting residents. What are some of the opportunities or things that you want the students to take away with direct primary care?
Well, first of all, I'm here with the Direct Primary Care Alliance, which is a physician organization. Our job is to educate about direct primary care as a model. And so every student and resident gets a free membership to join the Alliance because they are physicians in training. And so there's no expense there, so you get all the benefits of joining the Alliance. And secondly, we want to use those connections with the students and residents to be able to come to the medical school and be able to come to the residency program. And this is our mandate as a not-for-profit organization, so we don't charge anything to the program, we don't charge anything to the medical school. I keep saying, hey, we'll bring pizza and beer and have a bunch of medical students and we'll tell them about, it doesn't have to be complicated. I don't need a big stage anywhere. We just need 10 young people in a room to educate them about this model. And not all of them will choose it. I want to make sure that everyone knows. We're not trying to brainwash anybody here. We just want people to know about it because there are still students, even at the first and second year level, when they haven't even chosen a specialty yet. We need to get to them too, because once again, so many of us went to medical school with the concept of being a primary care doctor. And there's nothing wrong with getting there and changing your mind. Maybe you fall in love with urology. Maybe you fall in love with hem-onc or whatever. It doesn't matter. I'm not offended by that. We need good urologists. We need good hematologists. However, if you went and you wanted to be a primary care doctor and then somewhere along the way they changed your mind, someone changed your mind or some experience changed your mind, and you're like, you know what, primary care is not really as good as I thought it was going to be. Guess what? It is. You just got to be in the right model. And that's what we're trying to educate. And that's why we're here at the Future for the med students and residents.
Oh my God, Dr. Davenport, thank you so much for taking the time.
Absolutely.
We've been needing to have a conversation for a long time. Who would have thought it'd be at the middle of the Kansas City Convention Center?
That's exactly
right. And how appropriate for this very innovative model that's just getting a lift from legal terms to be talking about it at the Future conference. So awesome. Thank you so much for joining us.
All right.
Thank you, sir.
Thanks for having me.
This was great.
What are your thoughts on direct primary care, a rising tide for American healthcare? You've heard ours. Now we want to hear yours.
Email us at faiselandfriends@gmail.com and your question could be featured on the podcast.
If you like this episode, leave us a review and tell us how we're doing. And don't forget to subscribe wherever you listen to podcasts so you never miss an episode.
Connect with us on social media by following following Faisel and Friends.
And follow Primary Care for America on LinkedIn and Twitter.
I'm Dr. Faisel.
And I'm Dr. Dan.
And thanks for listening. This podcast is brought to you by Primary Care for America Collaborative and produced by Split Prism Productions.